Let's talk about reactive arthritis. Now, reactive arthritis, usually denoted by the word REA, is an acute non-purulent arthritis. Now, the word non-purulent is important, which complicating an infection which is found elsewhere in the body. So, the word non-purulent is important because it differentiates it with infectious arthritis. Because both the infectious arthritis, which are due to some kind of bacterial infection, or a non-purulent arthritis, which is not due to any local bacterial infiltration, can result due to an infection that is found elsewhere in the body. So simply, reactive arthritis is a complication that can result due to usually a group of infections which are found usually elsewhere in the body. Usually those infections which affect the intestine, they are most implicated in the etiology and the pathogenesis of reactive arthritis. But both the infectious arthritis and reactive arthritis have same symptomology. They both result in the swelling of the joint, they both result in the redness, all the typical inflammatory joints. The only difference is that reactive arthritis, the bacterial infection resides somewhere else, while in infectious arthritis, the bacterial infection starts and is present inside the synovium of the joint. Now, let's talk about its etiology. Now, to understand its etiology, we have to understand that it is a complication which results from an infection elsewhere in the body. Now, those infections can be due to a variety of bacteria. Now, these bacteria can be Salmonella species. All of the Salmonella species are implicated in reactive arthritis. We have Shigella species, all of the Shigella species, Yersinia enterocolitica, then we have Yersinia pseudotuberculosis, we have Campylobacter jejuni. Now all of these five bacteria which are usually implicated in reactive arthritis are of enteric nature, that they usually infect the gastrointestinal system. So these infection of these bacteria in the enteric area can result in complication of reactive arthritis. It is only the Chlamydia trachomatis which is not of enteric origin. Chlamydia usually infects the urogenital system. So if we have a patient with suspected enteric problems, usually Salmonella or Shigella or Yersinia are implicated. But if we have a patient with some kind of STI, then usually the implication is that the patient has chlamydia. Now all of these bacteria are sometimes also known as triggers for reactive arthritis, and these triggers can be antecedent to the reactive arthritis, that the infection comes before the reactive arthritis. They can come after the reactive arthritis, and usually because of their antigenicity, the antigens of all of these bacteria usually appears in the blood during the course of the infection and stays in the blood usually for years. So it is important to note that all of these bacteria have high antigenicity, that PCR is usually not of much help when diagnosing with these triggers. Now there are some other bacteria which are known as the less common triggers. They are not usually implicated in reactive arthritis. The most common of these is the Clostridium difficile. Now there are some studies that do say that it might complicate an infection into reactive arthritis, but the evidence again is conflictory. Other less common triggers with conflictory evidence is Campylobacter coli, we have Escherichia coli, we have the Ureaplasma urolithicum, we have Mycoplasma genitalium. All of these are not usually implicated as a complication for reactive arthritis, but there is some evidence in some studies. Now let's talk about its pathogenesis. Now, as for the pathogenesis, what happens is that we have a cell, and this certain cell is known as the antigen presenting immune cell. Now, it is known as such because it presents the antigen or the foreign body or a foreign molecule to the immune system. Now, this antigen usually comes from the bacteria which have invaded the body. Now, what happens is that these immune cells have certain adhesion molecules to them, which are known as the epitopes. Now, these epitopes, along with MHC2 class proteins, produce a kind of a coupled protein at the cell membrane. Now, when that coupling happens, what happens is that along with the T cell receptor, T cells start to infiltrate that area and start to couple with the immune cells, these antigen presenting immune cells. So, this kind of picture appears. So in this picture, you can easily see that CD4 helper T cell. Now the CD4 is important because CD4 are the helper T cells. Now a CD4 helper T cell has recognized the T cell receptor attached to it, and through the MHC protein, it has recognized the antigen. Now, when it recognizes the antigen, it also recognizes its structure and how to devise different strategies to combat it in the body. Now, one of the two ways via a CD4 T cell helps the immune system by recognizing the structure and the abilities of the antigen is that first it starts to clone itself. Now, whenever it clones itself, there's always a release of cytokines. Now, these cytokines, as denoted by these little exocytic products or secretions, are the ones which are responsible for the infiltration and recruitment of further cells like neutrophils, macrophages, mast cells. Now, all of these cells start to come at the area where this coupling happens. So, what happens is that we have a process of inflammation that starts to appear or starts at this point. So all the usual signs and symptoms of the inflammation actually start when all of these cells, especially the neutrophils, appear at the site where this coupling happens. Now, after the cytokines have released and they have started the process of inflammation through the recruitment of the other cells, what happens is that this T cell will clone itself. Now it clones itself because this coupling needs to be taken apart. So a clone T cell will not be coupled to an antigen presenting cell. And that clone T cell then further distinguish itself into two entities. Now these two entities being a CD8 cell and a B cell. Now B cell will then further differentiate into a plasma cell, and plasma cell, like we all know, are the ones which actually produce the antibodies. So when a CD4 helper T cell recognizes the antigen and then clone itself, it passes that information, that recognition of antigen, to the B cell, and when B cell matures into a plasma cell, it starts to produce antibodies against that specific antigen. So there's a flow of information from the antigen presenting cell to the CD4 T cell to the B cells, then to the plasma cells. And that is the reason that antibodies are very specific to a particular antigen. The other method by which this clone T cell helps is that by producing the CD8 T cells. Now, these CD8 T cells then further mature into a cell which is normally known as a cytotoxic T cell. Now, toxic T cells are also known as NK cells or natural killer cells. They are also are the ones which are known as the CD8 T cells because they present the CD8 antigen. So these cytotoxic T cells, whenever they are produced, they come in contact with the infected cell, the cell which is infected by the bacteria, and then they start to destroy it. Now they destroy that cell by producing two of these secretions. Now one of those secretions is known as the perforins. Now perforins are specific glycoproteins which start to perform punches in the cell membrane, and due to these punches or fenestrations in the cell membrane, the granzymes or the enzymes which have the ability to digest almost any molecule enter the infected cell. And when they enter the infected cell, they start to eat all of its components, from its cytoplasmic organelles to the nucleus. And when that happens, the infected cell starts to destroy, or sometimes the programmed cell death, that is the apoptosis, starts to appear, that the cell destroys itself. But whatever the mechanism is, cytotoxic T cells destroy the infected T cells, and they do so by first producing the perforins, which destroy the cell membrane, and producing granzymes, which then digest whole of the cell, resulting in the debris of the cell, which you can easily see here, that the cell has been destroyed and only the debris of the cell has remained. Now let's talk about the clinical manifestation of reactive arthritis. Its clinical manifestations are varied. They can lie at the both end of the spectrum, from the mild to the severe. At the mild of the end of the spectrum, we have transient monoarthritis or enthesitis. That we have an arthritis which appears for a limited time, or we have enthesitis. Enthesitis is the inflammation of the entheses. Entheses is the site where either a tendon or a ligament attaches to the bone. So we have either these localized symptoms or we have severe symptoms, like we have multi-system disorder, like it affects bones in both the upper limbs, in the lower limbs. It can destroy and complicate both the distal and the axial, both the peripheral and the median part of this body. So clinical manifestations lie at the both end of the spectrum. So if you get a patient which has a disease at the mild spectrum, you can easily treat it. But if the patient lies at the severe spectrum, the treatment of the disorder gets more and more complicated, and the chances of both morbidity to decrease also starts to disappear. Now, let's talk about its clinical manifestations. Clinical manifestations on a spectrum can be divided into multiple sections. Now, all of these clinical manifestations are usually reported by taking a good history. So, whenever you have a patient with arthritis, it all starts with taking a good history and performing a good physical examination. So, if we have a good patient history, usually the clinical manifestations or the patient history gives some kind of a record that the patient suffers from some kind of infection, and that infection is usually antecedent to the reactive arthritis, that it is usually usually appears 1 to 4 weeks before the appearance of the reactive arthritis. Sometimes in these patients, due to the advancements in the treatment of the disorders, sometimes these infections even get resolved even before the reactive arthritis appears. So you need to be careful in taking the patient's history, because the clue to the reactive arthritis usually lies in the history, because you might not have the patient which has an infection that is ongoing. Usually infection lies antecedent, that it is appears, resolves before the appearance of the reactive arthritis. Now, during the physical examination, you will get a triad of 3 different symptoms, and these symptoms are usually classically associated with reactive arthritis. And patients usually complain that they cannot see, they cannot pee, and they cannot climb the tree. Now, these 3 phrases can also be remembered as a mnemonic. Now, you can't see, pee, or climb a tree. Now, this mnemonic gives way to the triad that I was mentioning earlier. The triad being, as for the can't see, it is usually the conjunctivitis. That is the inflammation of the thin layer that usually covers the sclera around the eyeball. The can't pee refers to the urethritis, that the inflammation of the endothelium of the urogenital system. And can't climb a tree refers to the part of the triad which is the arthritis. That patient suffers from such a degree of arthritis that climbing a height is usually not possible for the patient. Now, continuing the clinical manifestations, these clinical manifestations can be clumped together in various categories. Now, they can be constitutional symptoms. Now, constitutional symptoms being the fatigue, that the patient has less energy for the work or activity, patient has malaise, that there's a psychological barrier to inability to work, the patient has fever, that there is heightened temperature of the body. Now, these constitutional symptoms are the symptoms which are commonly associated with any bacterial infection. So, they are usually present in a reactive arthritis. Other symptoms are like weight loss, again, is a constitutional symptom. Now, other symptoms can be musculoskeletal symptoms. Now, musculoskeletal symptoms are usually can be of mild origin to severe. Now, they can be simple arthritis, that inflammation of a joint. Now, that joint can be a joint of a finger, that there is a minor arthritis, or there can be dactylitis, or that is usually known as a sausage digit. Now, dactylitis usually means the inflammation of the whole of the digit or the whole of the finger. And the sausage digit usually means that only one of the 5 fingers is involved, the rest are severed. Now, because only one of the finger is involved, that inflammation results in the swelling of the digit, and that results in a typical picture of finger appearing like a sausage. Now, there can also be tendinitis or fasciitis. Tendinitis again is associated with anthenitis, and fasciitis is the inflammation of the fascia, which are usually found inside our body. They are usually found around whenever there is a cluster of bones or a cluster of different viscera, like in the hands, in the feet, or in the abdomen. We also sometimes have spinal lobe back pain, which is usually associated with this, and sometimes buttock pain. But buttock pain in the reactive arthritis is usually of the alternating type, that it transfers from the right to the left. and that can give you some idea that the patient with this kind of symptomology can have either an antecedent infection or an ongoing reactive arthritis. Next are the urogenital lesions. Now, these urogenital lesions result in urethritis. Now, for the males, urethritis either results in marked morbidity or the same as it was with the antecedent infection. But as for the females, it can result in others infection of the other sites, such as the cervicitis or the salpingitis. That is the inflammation of the cervix and the fallopian tubes. So, urogenital lesions in females are more dangerous than in men, because in men they only affect the urethra or sometimes the prostate, resulting in prostatitis. Next, we have the ocular disease. Now, involvement of the eye is usually considered a hallmark of reactive arthritis, like mentioned in that triad, that conjunctivitis is part of the symptomology of the reactive arthritis. So, it can result in a transient asymptomatic conjunctivitis. Now, transient means that it happens for a limited time. Asymptomatic means that the inflammation does not affect the ability of the patient to see. The visual acuity is not hampered. Or it can result in an aggressive anterior uveitis. Now, uvea is the area that lies between the iris and the ciliary body. Now, this inflammation of that area can result in a lot of symptoms. It can result from the patient, it can result in patient's lowered visual acuity to complete blindness. So, uveitis, or especially anterior uveitis, is considered among the severe spectrum of the course of the disease. Now, because of this aggressive anterior uveitis, blindness can happen, because uvea, like I said, rests between both the iris and the ciliary body, and the ciliary body houses the lens. Now, if there is inflammation of that area, that lens, the ciliary body, and the iris, all of these can get inflamed, and because they get inflamed and swelling starts to appear, the appearance of light into the eyeball and then onto the retina is hampered. It does not go through the lens, and because of this, patient can complain of blindness. Next, we have the mucocutaneous lesions. Mucocutaneous lesions in reactive arthritis are usually transient and they resolve on their own, but they can result in certain problems that can persist. Now, they can include the oral ulcers. Again, oral ulcers are usually transient, asymptomatic. They are usually only found on examination. Patients usually do not complain of oral ulcers which have more morbidity. Now, they can also result in skin lesions, which again is very rare. It can result in a specific condition known as keratoderma planorica. Now, keratoderma planorica is a condition where pustules starts to appear on the skin, and these pustules then again start to crust. And when they start to crust, a typical picture of a crusted boil present on skin is presented on the patient. And this is a very typical picture of a patient which has both autoinflammatory and autoimmune etiology to its disease. So these patients with this keratoderma must be taken seriously, because skin lesions in reactive arthritis are usually transient and asymptomatic, But if they have progressed to such a degree, to such a severity that they have resulted in a keratoderma, then you can expect the patient's reactive arthritis to be severe too. Next are the nail changes. And nail changes in reactive arthritis can result in onycholysis, that is destruction of the tissue of the nails. It can result in distal yellowish discoloration, and it can result in heaped up hyperkeratosis. That is, the nail bed starts to produce nails that have more thickness to them. And whenever they go off the nail bed, their thickness starts to increase even further, resulting in a very typical appearance of a hammer like nail. Now, next are the rare symptoms. Now, these are the symptoms which are usually only found when you either look very hard or in very few patients. Now, these rare symptoms are the cardiac conduction defects, that there's some kind of a problem between both of the nodes of the heart. It can be aortic insufficiency due to either maybe dissection or due to the hardening of the aorta. Aorta is not performing to its utmost efficiency. Then we have the nervous system lesions, again, are very rare but can present as a clinical manifestation in a variety of neurological problems in reactive arthritis, because like I said, it is both autoinflammatory and autoimmune disorder. Now, another thing is that they can also result in pleuropulmonary infiltrates, and these infiltrates can result from harmless infiltrates which lie usually at the hilar area to the ground glass opacity. Now, depending upon the severity of the infiltrate, you can also judge the severity of the reactive arthritis. Now, let's talk about the diagnosis. Now, for the diagnosis of reactive arthritis, lab tests are usually not enough. There is no specific lab test that can be easily performed and which can easily be done to diagnose reactive arthritis. There is no specific test for it, but there are tests which, upon their performance and their result, we can expect both the course of the disease and the severity of the disease. Now, these tests are usually come from a suspected patient. Now, suspected patient is when you have a patient which has both that the triad, that it has the both the conjunctivitis, the arthritis, and the arthritis, along with additive arthritis or tendinitis. And because that arthritis is usually asymmetrical, you have high suspicion that this patient can have reactive arthritis, usually at a peripheral site. Now, in order to have this kind of an assumption, you need to have proper and good history of the patient. Now, after the patient's history and a proper physical examination, now for the proper physical examination, you need not to look at the major synovial joints, but you also need to look at the smaller ones, like those which are found at the distal interpharyngeal joints or the proximal interpharyngeal joints. So you have to perform both the history and the physical examination to the utmost of your ability. Now, when you have a suspected patient, the questioning should be more about the triggering events. Now, usually, like I said, the triggering bacteria can be of two origins. They can be either enteric or urogenital. Now, enteric bacteria can result in some kind of a problem such as diarrhea or some kind of inflammatory bowel disease, or they can result in some kind of urogenital lesion such as with chlamydia. Now, as for the chlamydia, the history for both the STI and the history for the patient's sex partners must be taken with utmost care. Now, this being a sensitive topic, should be taken either with the help of a senior or someone who is adept at taking them. Next, whenever you have a complete set of history and a complete set of physical exam, you have possible sites of involvement. Now, these possible sites of involvements are then further investigated. Now, when they are further investigated, they can be investigated either by synovial fluid analysis. Now, in reactive arthritis, synovial fluid analysis usually does not give you any kind of indication towards the diagnosis, because it will only give you that the patient is having synovitis, that is some kind of inflammation that is going on in that synovium. You can also perform the culture of that synovial joint, and through the culture and sensitivity testing, you can find out that which bacteria or which kind of bacteria is affecting the patient. Usually, the type of the bacteria which result in reactive arthritis are of gram-negative type with a liposaccharide capsule around them. And because of this, a culture of a synovial joint can easily be performed. Now, after the culture, serology of the patient is performed. Now, by serology, we measure different markers which are present inside the blood. Now, the rise and decrease of these markers can help us in diagnosing both the antecedent infection and the reactive arthritis. Lastly, we can do HLA-B27 typing, because in reactive arthritis, about 40 to 50% of all patients have some kind of association with this protein. So B27 HLA typing must be performed, because it is found more in males, in white males. So there's a very strong epidemiological association of HLA designation B27 to reactive arthritis. So B27 typing is also carried out, because it has a very high diagnostic predictive value, it is performed. But you need to know that only about 50, only up to 70% of the patients can have B27 in their system. So this is again not a definitive test. Next, we're going to talk about the other tests, the test we perform in the serology of the patient. Now, these tests can be ESR, the erythrocyte sedimentation rate, and that ESR in a patient of reactive arthritis is always raised, because like we know, more the inflammation, more the ESR. We can also perform serology on acute phase reactants. Now, acute phase reactants are either positive or negative. Positive being that they increase during the inflammation, and negative that they decrease during the inflammation. Now, positive ones are the fibrinogen, the ceruloplasmin, the C-reactive protein. Now, these one are C-reactive protein is the most common acute phase reactant which is performed, and you will find that all positive ones will be raised. Next, we will find that patient will have mild anemia, and that mild anemia is again due to the widespread sepsis and inflammation of the body. Next, we have synovial fluid. Now, synovial fluid again will appear inflammatory. It will not give a specific diagnosis to the patient for the patient, but it will give you the hint that patient is suffering from total systemic inflammation. Next, we will find out that B27 HLA is positive, because most of the times it is positive in patients of reactive arthritis. Next, polymerase chain reaction. Now, polymerase chain reaction is performed on the antigens which are usually left or found on the bacteria which usually infect the patient. Now, the problem with the PCR is that these antigens can lie in the blood of the patient for about from weeks to months to even years. So a PCR test of the antigens of either Salmonella or Shigella or Yersinia or even Chlamydia will have no effect on the diagnosis of the patient. But you can have a certain amount of help in that you will form a kind of a provisional diagnosis through PCR. But then again, because of the culture, we already know what type of infection of the bacteria is. Next, in the diagnosis, we'll talk about the radiographic findings. Now, as for the radiographic findings, they are usually categorized as there is usually juxtapositionary osteoporosis, that patients on x-ray suffer from osteoporosis, that the density of the bones is lessened, there is increased there's decreased amount of spacing between the bones, and there's increased amount of reactionary bone formation. Now, all of these osteoporosis, along with narrowing of the space between the bones, is considered hallmark for the diagnosis of reactive arthritis. So, in this patient, you can easily see that this patient is suffering from osteoporosis, and this osteoporosis is juxtaimposed upon each other, that all of these bones which are superimposed upon each other have one thing in common, that all of these have low density, that they are osteoporotic. Another thing is that they will have lessened amount of spacing between the bones. And this narrowing of the spacing between the bones tells us that there is some kind of inflammation, and then fibrotic changes are happening which are lessening both the amount of the space between the bones. And we will also find some other changes such as erosions and reactive bone formation. Now, erosion you can easily see here at this point. The bone is eroded at this area, and this area is also the site of the insertion of the Achilles tendon. And this is also a site which is known as an entheses, the site where a tendon inserts into a body. So this is a site of both of an enthesitis and of bone erosion. Next, now on digits, we will have usually typical findings. Now these typical findings are usually termed as the penciling of the carpals or tarsals. Usually it is with the tarsals, or a typical sign which is known as the pencil in the cup sign. Now in this x-ray you can easily see that these bones are thinning and forming into a thin like barreled structure like a pencil. So this is what is known as the penciling. And because of the erosion and the subsequent outgrowth of the bones around the synovium, there's a cup-like formation. And because of the penciling of the carpals and the cup-like outgrowth at the other end, either at the metacarpals, we get a typical sign of a pencil in a cup. Now the cup forms due to the outgrowth, and the pencil forms due to the thinning of the carpals. Next, we'll talk about the treatment of reactive arthritis. Now, for the treatment of reactive arthritis, NSAIDs are the first choice, and NSAIDs are also given in high doses. Now, because NSAIDs are given in high doses, They both help in the pain of the patient and they also help in the inflammation of the patients, because we both know that NSAIDs not only reduce the pain but are also effective in reducing the inflammation at the area. Next, we have antibiotics. Now, a prompt antibiotic course might help your patient with reactive arthritis, even though there is little evidence that it will affect the prognosis of the disease, but it will have some effect on the quality of life of the patient because of the antecedent nature. Because of the antecedent nature of the preceding uh, bacterial infection, uh, a prompt antibiotic course might have some effect on the patient, that it will perform some kind of a prophylactic effect. But because the infection is always antecedent, that it has happened before, it will not have a much greater effect on the outcome of the disease. Next, we have the intralesional glucocorticoids. Now, intralesional glucocorticoids or synovial steroid injections help in the controlling the inflammation of the joints. Next is the patient counseling. Now, patient has to be counseled that reactive arthritis is due to a preceding infection which was either cured or wasn't cured, and it is a result of that infection and it will run its course because it is an autoimmune disorder, and an autoimmune disorder usually goes on for life. It can be managed, it can be treated, but it can never be cured. So you have to counsel the patient. Now, for the treatments for NSAIDs, the choice we have among all of the NSAIDs, from the acetylsalicylic acid to diclofenac, indomethacin is the NSAID of choice, and it is usually given in dose of 75 to 150 milligram per day in divided doses. Now, we also have certain evidence that other medicines such as anti-TNF alpha monoclonal antibodies like adalimumab or infliximab, they can also help. Certain interleukin receptor blockers can also help. So there are certain studies that are going on which can help you in managing your patient. NSAIDs are not your only choice. Along with the intralesional glucocorticoids, there are other medicines, but the application of those medicine along with certain immunosuppressive drugs is managed patient to patient, that it varies patient to patient. So you need to decide it on a patient basis. Now, for the treatment antibiotics, we have now the course for the antibiotics is given as either one of the two choices. The first choice being that we give a 6-month long course of rifampicin 3 milligrams daily along with azithromycin 500 milligram daily, that is in OD dose, for 5 days and then twice weekly for the rest of the 6 months. Either this course of the treatment is followed, or we give 6 months of rifampicin 300 milligrams daily along with doxycycline 100 milligram twice daily. So rifampicin with either azithromycin or doxycycline is given as a course for 6 months in patients with reactive arthritis.